Welcome to the Sultans of Sales podcast. I'm your host, Jamil Pendleton. My friends call me Jay. Thank you so much for joining today. On the show, we have Juan Uribe, who likely needs no introduction, but we're going to give him a proper introduction anyway. Dr. Uribe and I met years back, and he's currently the chief of spinal disorders, the chair of the Sontag Spine Research, and vice chair for neurosurgery at the Barrow Neurological Institute, BNI, in Phoenix, Arizona. Dr. Uribe, thank you so much for joining the show. Welcome.
Jay, I'm very excited to be in your show today. That's an honor for me.
Wow. Well, it's an honor for me, sir. And again, surgeons like yourself are why I actually have a job, having worked with spine surgeons for a better part of my professional career. And then now moving into this new age of digital interaction and gathering and podcast on YouTube. So it's fun for me. I'd like to dig in right away of your path discovering MIS spine surgery. What can you share with us? How did that start? Would love to hear from you, Dr. Uribe.
Yeah, no, that's a very interesting and good question, Jay. So I was trained like most of the my generation surgeons on straightforward open techniques. Right. And, this huge incisions, big blood loss, patients stay days in the hospital with drains, waiting for the output of the drain goes down, and then finally they start finding the way home. And, I always wanted to challenge what is conventional. And I always say, why you have to move all this soft tissue to get access to this very little segment when you do your case, specifically in 1-2 levels and that. And that's how I start thinking, can you do it smaller? Can you take less footprint and get similar results? And obviously pioneers like Kevin Foley, Luiz, Pimenta, all these my mentors on MIS, they basically opened the road for us to start doing it. So that was my main motivation, Jay.
It's amazing. And, having you and I cross paths during my time at Nuvasive, and you've now performed more than 1,650 X lifts. Wow. What have you learned? What have you learned from that experience?
And the X-lip surgery, the lateral surgery to the spine actually is a very interesting surgery. And that's what I became so passionate about it, because not only is minimal invasive and is a very challenging in terms of disruptive solution to access the spine, now from the front, not from the back, just this unique corridor that is actually, the body has it, that retroperitoneal is like an amazing highway that you can get into the spine. But then like everything in life, there was these stones, or I will say these barriers to make it work perfect. And which was for me the biggest challenge is that we start doing these lateral cases and patients start having these femoral nerve injuries. As you know, it's a well-known complication of the lateral surgery. And the interesting thing is that with the particular way that we were doing it, we were having less type of that complication. And then became a very interesting situation between all the surgeons and obviously the industry get in the middle. As you know, you as an expert on the industry, you know that when the dollar sign is behind it, a lot of things happen. And, at that time, this company was eroding the market share of the big, 500 gorillas on the field, and right. They have to respond with something. But the problem is that they came with a alternative that actually was not necessarily safer or better, and the complications start having, showing up more and more. And that's why it became to me like, okay, so my role is to show that actually this access the lateral access to the surgery safer, but we have to show it in a scientific way. You know, as you know, Jay, I don't get nothing by telling you my patients do great. And then you're gonna say, okay, great, Dr. Uribe, good luck, you know? So the question is, how can we make sure that scientifically and with facts, we know that it's actually a good procedure, and not only that, but can be spread to the masses, you know, can be reproducible. And that's what became the challenge for me. And obviously, I like it, and the numbers, you know, I'm doing it for, it's not like I'm abusing the indications, it's just I've been doing it, I started too early with the lateral. You know, I've been doing for more than 10 years, lateral access to the spine, and the numbers goes there. And as always, want to push a little bit more on that. You know, what about if we get in the thoracic spine? What about if we try to get more lordosis and we do the, you know, anterior section in the ligament, this and that?
Yes. And interestingly, you're well published, to your point of bringing the data to truly change what surgeons are doing, and your peers in the, you know, out there in their communities and their markets, you know, 142 publications, peer reviewed, 51 book chapters, right? That's incredible. And it takes a lot of time and effort and, you know, I would say just extra things added on to your already busy schedule. So thank you for that, because that spurs innovation. I've talked to other published surgeons, and it's just so great to what you're doing, you know, for not just your patients there in your market, Dr. Uribe, but for the greater good of spine surgery.
Yeah, and you know, Jay, publications is, I would say, in the regular world, is a way that you leave somewhere your job and for the next generations and for the people out there. And also it makes you honest, you know. And if you look at my publications, most of my publications actually are complications. You know, I'm never afraid to show what goes wrong, what happened, trying to understand, and then let the community know, because I'm sure that doing that, I'm protecting others and I'm helping the field. Yes. I don't get nothing again by tell you, oh, my patients do great, I never had complications. Listen, it's like a car drivers. If you drive cars, you have to crash, you know. That's and right. The best ones, unfortunately, like Senna, all these best drivers in the world, they die on the track. So you have to understand that complications are part of what we do, and we have to understand, trying to work them up and move forward. Obviously, not to ignore them because you're hurting people, but your job is trying to learn from them and trying to prevent others from doing it. And that's part of the game, and the publications are along with that.
You know, and I think you've done just a fantastic job of that. You know, taking a step further of like leaving a legacy, which is one of our later questions. I think I sent you ahead of time, but you mentioned that, like, what are you leaving behind, you know, after your time? And recently I've noticed your posts, that's, you know, particularly on LinkedIn, but, you know, I'm sure there's other mediums as well. Your posts on new technology, right? And so before we talk about the posting and the LinkedIn post that actually, ironically, I don't know if you know this, but your public support of Vision had a huge impact on my decision during the due diligence process of where I was taking my career, which is pretty powerful because I've known you, not well, but just we've known one another through the years. And to see your statement of what is enabling technology, you know, for me, check the box about this company and a next step for me. So thank you for that, Dr. Uribe, because it had a really big impact, even though you may not have known that.
That's amazing, Jay. No, I can tell you that one of the good things also on the MIS spine surgery is that it's too much attached to technology. And, you know, all of us, we love technologies. You know, we die for the new iPhone, for the new gadget with that. And, right. This makes your job part of your life because you're just trying to see. And if you can be in the tip of the arrow, that's amazing. And as you mentioned, for example, technology like Vision, you know, Vision is just for the audience, this is a small camera that you mounted into your retractors. And what it does is basically is like you have eyes on your back, you know, it's like you spread the entire OR and the people around you. You show them, what are you doing? This camera has a high definition, show exactly everything that you've been doing. And sometimes when you do minimal invasive surgery, is you're the only one who sees it, who see what's happening. And even for the teaching point of view, is an amazing resource. And this is one of these things where you adding a small piece of technology into the equation and actually make a big impact. And this is something that I'm trying, you know, I love LinkedIn because probably is our best, I would say, social platform for professionals where, you know, because, you know, Instagram, the other ones are great, but it's more like for personal, you know, this is something that you can go deep in what you do. And since I'm so passionate what I do, I found like that's my home in terms of social media. Exposure. I know that you're huge on LinkedIn, Jay, and I follow you, and I can see how much you influence all over the world. And I can tell you that these enabling technologies are probably the path to change what we do in the next few years. And it's going to be, I like, you know, one of my passions are cars, you know, wanted to know why, but I can tell you it's very similar to the car industry. Okay. We're not expecting a flying car in the next 2 years, you know. What really making the difference the last 10 years is incremental changes, you know, like the airbags, let's say carbon fiber. Now, obviously, the Tesla was disruptive in terms of it changed the drivetrain dramatically from gas to electric, but still, it's the same car. It's 4 wheels, or it's a chassis, it's a suspension, it's a steering driver. So I expect from the spine, we're gonna continue having these incremental pieces of technology that are making this surgery safer. We're not waiting for the next X-Leaf or the next kyphoplasty or the next pedicle screw, you know. It's going to be more like these little enabling small techniques, you know, navigation, robotics, vision camera, better optics that really, you know, and then now with the, you know, now that we have all the synthetic data and, you know, even the metaverse is going to be also touching our field, which is going to be very exciting. I mean, hopefully I can keep doing this for, you know, 10 more years so I can witness this big revolution in spine.
That's amazing. I could not agree more. And I think it's a phenomenal analogy that you made to the car industry and specifically just incremental change, because I think, Dr. Uribe, that's how change happens. It's this small yet incremental, consistent application of something that enables what you're doing today, right? Without disruption of workflow, but it changes the output of your surgery. So you're able to treat your patients the same way and accomplish your surgical goals, yet the whole room can watch. Or, for example, for navigation, robotics, you can become more precise, back to the pillars of lateral surgery, safety and reproducibility. And so I really, what would you say for a learning curve? That kind of gets, when you talk about new technology, there's always that, well, my patients do very well from a surgeon standpoint, or there's a hesitation to change. But you seem to, it sounds like, embrace the disruption, embrace the change. What can you share about that, about the process of learning new technology in your hands?
Yeah, that's a great question. Yeah, and please call me Juan, okay? No
okay. Yes, sir, Juan.
Yeah, we're friends, okay?
Yes, sir.
So, no, I would say, Jay, you know, going back to where you're talking about, you know, how technology is going in here and how you know, one of the most difficult parts of the minimal invasive surgery is actually training. You know, training people on MIS is very hard because it's only one man show and no one see what you're doing. And as I mentioned before, you know, things like vision makes this easier. But the question is how you adapt and how you get into new procedures. And as you mentioned, for us, it's easier, you keep doing what you're doing and works, and in our field, it's complicated to get something new because the price is paid by a complication, a patient mistake, and there is a learning curve. So it's not like you go to Home Depot and you try a new drill and then you break the drill bit and then you just go a new one and nothing gets wrong. And the little hole, you put a little bit of, duct tape or whatever, and you fix it. And here is paralysis, wound infections, OR time, pain. But I can tell you that there is many ways to do it. For example, one of the enabling technologies, which I don't know, you see it on LinkedIn, we started this lab of virtual reality and augmented reality at the Barrow Neurological Institute. And the only reason that we're doing this is to actually facilitate the adoption and the learning of the residents and in general, the surgeon's new techniques, because if we can create something similar to the flight simulators, it's going to be similar to that. And in medicine has been this traditional way to teach that has been for centuries, which is you follow me, you watch me, then you start doing little by little, and then finally you master. But I'm surprised, through my career, that how come we don't have our training similar to the airlines training, And the best example is this way, Jay. Let's put it, I'm going to put you on this case scenario. Okay. So you're going to go to, let's say, to New York, okay? You're in Dallas, correct? Dallas to New York.
I'm in Austin.
Okay, so
close enough. Dallas,
sorry, Austin.
That's
even
okay.
better.
Yeah.
You're in the hot city right now.
Oh, one. Okay. All right. I don't know. Much love to Dallas. That's my hometown, but okay. I'm in Texas.
You're in Texas. Okay, let's put it. Texas to New York. Okay. So you get on the airplane, and when you get your seat, suddenly you hear on the speaker on the plane, okay, welcome all the passengers. We're going to New York. It's going to be a 6-hour flight. And we're excited because our pilot, he just graduated from college on piloting, and he's going to be his first flight ever. And he's ready to go, and he's been flying little here, there. But so, I mean, what will you do?
I'm out of my seat.
You're out of there, yeah. So that's what I say, how a pilot get trained, So the airline industry, because what happened is when an airplane crashes, is 250 souls or 150 souls that died. It's a very grotesque event, When it's a complication in surgery, it's one patient at a time. You never have 250 patients dying at once, or having a complication. So that's why on the airline industry, obviously there were all the resources to prevent that. But what I say is, if you see how a pilot get trained to fly, and it has a very clear thing. They have these flight simulators that they have haptics. That is $2, $3, $4 million easily one of the flight simulators, but it's so close to real that when a pilot meets all his requirements, he can get into the plane and fly like nothing. And these go train. So what I'm trying to do is, can we recreate something like that on the spine? In other words, when our learners come into the OR, they already check a bunch of boxes. They just need to flow and do what they've been doing in the simulator. So
love that.
That one obviously will help a lot on the field. And I will say, if I can get retired and I can walk away knowing that now everybody go to a better learning curve and is more standardized and the outcomes are better, I will probably can go and, play golf my last 10 years of my life, like no tomorrow.
Right out into the sunset. Well, it seems like that's a passion of yours, and it's a shared, I would say, passion of mine is improving things the way when you arrived and leaving them in a better shape. So in this case, MIS spine surgery. And so that's amazing. I wanted to ask, let's talk about the international impact though of the flight simulator, if you will, or of these enabling technologies which allow for training at scale. So you're from Medellin, Colombia, correct?
Correct.
Right? And you've operated on every inhabited continent, which is incredible. I'm a world traveler. I took a gap year, traveled around the world. And I love that, just, which is a pretty incredible statement, Dr. Uribe, sorry, Juan.
Yeah,
but you think about what the ability to connect with other surgeons in Colombia at scale through digital means, through training and helping the world, right, adopt these new technologies, which are better for the patient, but are more difficult for the surgeon. Can you talk about a world maybe where you see in the near future where these things could be possible? And I'm not sure if that's a great question, but just love your perspective given what you've done.
And that's a big limitation. You know what? Healthcare is expensive business, as you know. Here in America, we're privileged because we have access to all the toys. And I always say, for a surgeon like me, be able to practice in America is the equivalent, for the audience that are not on the medical field, or reps, or anyone that is in here, is that is the equivalent, for example, for a soccer player be able to play in Europe, or for a cyclist be able to be on the Tour de France. So this is, America is that the best scenario, the best arena where you can have all the toys, you stay on the tip, but does not happen in the rest of the world. So the point is, being a Colombian, being from South America, knowing, and it's not like I'm Colombian because my parents migrate and I was born in here. Actually, I did med school, neurosurgery in Colombia. So I know exactly what is the story, how the water runs in South America, know. Mm-hmm. And I can tell you that obviously the biggest limitation is the access to cutting edge technology, which is very expensive and comes with a significant price. But part of that also is, how can we have access to a better training? How can we get training a more standardized, high demand environment? And I think, as you just mentioned, you just put it there, all this globalization, all this, virtual reality, augmented reality, even artificial intelligence, it will make the exercise of in other words, is not fair that you have to be in America to have a good MIS, let's say endoscopic for aminotomy or a lateral, or you have to be in a well-developed country. It's not fair for the humankind.
That's
so
right.
You should be able to have, everybody should be able to have access to that. And the problem is when we try to go there, for example, and we do some surgeries, which we do it, a couple of times a year, the impact is very minimal. You train one surgery at a time, and then it does not really change in the whole equation. It's like I'm opening the door of my house, trying to cool the entire Arizona with
for 1 week.
Condition. Exactly. So it doesn't work,
In having been on those mission trips, which are just the most incredible thing that I think that I've ever done, was being in Africa and seeing exactly what you're talking about. Seeing the conditions, the fact that people have walked for miles, for days, to come during that week of time where spine surgeons and industry are coming and donating their time and their, the instrumentation and the implants, whatever. And sometimes that pathology, as has changed, or it's not time to operate. And it's like, it's such a sad reality of the situation of the discrepancy between how we have it here versus how the other places in the world have it. And one thing that I realize, or that I recognize, is the Mozambicans, for example, or the Kenyans, for example, they're very well studied, book-wise, book smart, if you will, on procedures and pathologies and these things. But having not seen the instrumentation, they don't know how to use that instrumentation. And so it's such a light bulb moment to see them, like all these things that they've read about, maybe some of your publications, and then they can actually do those procedures for that week of time. It's like, I would love for there to be, in our lifetimes, an opportunity for them to do those on the regular, would be incredible. And so,
yeah. And as you mentioned, there's a lot of potential, I mean, surgeons and the knowledgemen, and they're super skillful all over the world. They just don't have the right tools,
That's right.
And, you say you're a golfer, it's very hard to play under the par if you're shooting with not with the right tools, with
That's
bad
right.
balls, So definitely the talent is there. It's just the enabling technology.
The enabling technology.
Okay. What makes the limitation in here. And no, I'm definitely convinced that we're on the right track. It just takes a lot. But you see, for example, even in LinkedIn, in the social platforms, how surgeons all over the world chime in on, sometimes when you show cases or when you highlight technologies, or you definitely, it is just getting much better. And even I see when you put your own posts, there are, because sales reps are so important to me. Sometimes you hear that you have to take them out of the equation to make the healthcare cheaper,
Right. Repless models.
Yeah, they don't understand. Sometimes they don't understand the value of a good, sales rep in the OR. The amount of value that you guys bring is impossible. And we have examples where the hospital tried to run by regular, generic personnel, some of the products that we use, and you can see that it is not there. And also, at least in my case scenario, my reps, they actually bring value to the case. They help me to train my residents, believe it or not. They help me with I mean, it's amazing.
Absolutely.
And I will say, you've been very instrumental on that aspect, Jay, to tell people that, because you bring value through LinkedIn, they understand what is your value. I mean, that's a really good way to protect and keep promoting the field.
Thank you. Wow. That's incredible to hear from multiple standpoints. I mean, I think the interoperative consultant or the rep or the vendor, right? We get a bad name, right? I remember when
What is the best name? I hear bad when they say vendor,
Yeah, vendor.
And they put these red caps,
Exactly.
That's so annoying.
The red cap, which I recently had to wear my first one because it's kind of become now the standard. When I hung up the rep cleats in 2017, I was wearing surgeon caps. It was kind of a different mentality, but I'll never forget. I mean, my first few days,
that I've been before I was in here, we don't have in Arizona, we don't have the red cap thing. But when I was before in Florida, actually, I was wearing the red cap on the surgeries, listen, this is, I don't get it,
You were? Oh, that's amazing.
Yeah, it was funny. I was like, I'm going to use the red cap today. What about that?
I love that. I love that. It's just, look, I get it though. There's always going
everybody
to be.
knows there's 5 people in the OR. Who's not going to know who's the rep?
I know. Well, I think the intention, and just like social media, the intention of, let's say, Facebook, you mentioned kind of Instagram and Meta and all this stuff. The intention was good. It was to connect people, but I think the byproduct, can be negative, because what happens is people stop calling their friends and they just catch up on what they're posting and they feel everything's happy. And, unfortunately, the social media is a double-edged sword. You get kind of the highlights and the best, the way in which people want others to perceive their lives. But you see the great picture, but you don't see like the moments before where you're trying to wrangle your kids. And, similarly to the idea of vendor credentialing and all these things with the red hats, it's like, it's good to know who people are in the operating rooms. But to your point, back to the repless model and why that's a sham, and you know, at least for spine, in my opinion, won't work. It's sometimes it's the rep is the person in the room that you, as a clinician, as a physician, are looking to in a moment of where the plans change. And all due respect to everyone in that room, the surgeon's looking towards their rep for options, and for just consulting on that, and in the moment, in the case, with the patient on the table open. I don't understand how that could ever be removed.
To me, Jay, I mean, I like to make analogies. Let's say that I'm a professional PGA golf player. To me, the rep is the caddy, the best caddy ever, you know? I cannot win tournaments without a good rep. You know, I cannot have a good surgery without a good rep, you know? For example, on the X-sleeve surgery, on the lateral surgery, where the time of retraction of the lumbar plexus is so critical, I have to have a perfect flow. And the only way that I can do it is I have to have a perfect rep that knows exactly what is he doing, what is the next step, coordinating everything that I cannot do, you know, because I'm being focused on the wound, on passing the instrument, this and that, but everything that happens around me actually is governed, is coordinated by the rep, you know, and that's why I'm always dedicated my career, I will say, to build an amazing team around me, because you know, you don't do nothing by your own. Everything that I have, even the publication, everything is a team. You know, the outcomes of my surgery is because of a team. You know, I'm just the guy executing, but it's a lot of things behind it. You know, for example, this is so critical, Jay, that sometimes I'm almost ready to cancel a case if I don't have my scrub tech, my rep, and my own team. Because I know that I'm going to compromise the outcome. It's not fair for the patients, It's not just for me to go home early. It's just because, you know, that 10 minutes of more, for example, on the X-sleeve, and the best example is this: if I put my fingers on my eyes, if I keep it for 1 hour, I promise you I'm going to be blind. But if I put it for 10 seconds, I'm going to be fine. Yeah. So with the retraction of the lumbar plexus on the lateral surgery, it's the same. So if I can retract this for less than 10 minutes, I promise you, you will never have that complication. And that's how amazing. I'll do it, having an amazing team around.
Yeah. And we talked about, I mean, you're so right. And having been part of those teams, it's such an honor to be a spoke on the wheel, right, of that patient story. It's well said, because it is a team, and not to make this a Vision commercial, but hey, it's my show and they're my employer. They write my checks now. How has Vision, when you enable, because I've been in these rooms now, I've stood in these ORs and I see things, Juan, that I've never seen before. For example, an annulotomy, right? I've done it on cadavers, I've seen it, but I've never seen it when it matters the most, or just the cob, getting that contralateral. Can you describe what this technology has done? And again, this will be something that we talk about in Las Vegas. I'm emceeing that event that you're speaking on our behalf. So thank you so much. And it's coming February 24th during Spine Tech Summit. But can you talk about that element of putting what you're seeing down the wound or the tube out to the OR synchrony that takes place, or from your reps to your scrub techs to your circulating nurses? I'd love to hear your experience using this technology, and just kind of your thoughts.
And part of the advantages of, I would say, the good features of the Vision, and having this real-time visualization of what I'm doing to the entire room, is that it promotes anticipation. And anticipation in surgery is a big deal. When the scrub tech knows that I'm getting a lot of disc out because he can see it on the screens, when the tech knows that I'm just getting out of that stage, immediately she knows that, or he knows that the next instrument is going, you know.
That's it.
Same thing for the rep. The rep can start, because you guys has to time a lot of things, just opening the graph material, you know, for people that are not surgeons or are on the field, you know, when you pack these cages with bone, so we can promote the fusion. Some of those products are time dependent.
That's right.
So you have to open at the right time. And, the way that we do it traditionally, I'm doing the surgery, no one knows where I am at. So I have to remember 5, 10 minutes, 12 minutes before that we have to start packing the graft. So now actually, because I open the window and give an eye to the entire room, then I don't even need to know that. So that brings value to my surgeries, brings value to that. And this is all about, that's how, for example, and I can tell you, Jay, in the future, that's what I see also a lot of, even from the legal point of view, every surgery has to be recorded. Just see the police guys, the body cam,
That's right.
I can tell you, sooner or later, physicians and healthcare, we're gonna have a body cam somewhere, We're in the era that everything is being witnessed, Everybody has an access to the camera, everything is up front, up there. So vision is actually along those lines, You exactly is one more piece of reality of what's happening, what happened. It's not like he told me, I told you, I said, he saw. You just listen, what you see is what you get.
Yeah. I mean, this is unfortunately a litigious society. And, I definitely hear what you're saying. And those are just some of those byproducts, like an ergonomics, right? When I first saw this product, I didn't think about that. But now it's one of the best. It's when you look at our index score where we kind of show the differences with and without, it's awesome to see that the delta of ergonomics is just the biggest, because you're, instead of looking down, you're looking up. And anyway.
Yeah. And see, for example, when we're doing this lateral in prone position, we are very awkward, and the vision will, in that camera, for example, decrease that. I'm trying to, because I like to put scientifically everything. I'm trying right now to find a way to validate what is the value of the ergonomics, because we know that in the long term, your neck will be, if every day you stare 5 hours like this, you're going to end up with a problem. But what I'm trying to do is, with these new wearable devices, we're trying to now check what is the strain on the neck muscles when you do these surgeries with and without the vision.
That's great.
We can show a little more, scientifically at least, that what actually these technologies make a difference, just not right there where you're doing the surgery, but the collateral effect.
Incredible. I mean, honestly, that is amazing, because you're right. I mean, you can talk about time in the OR and how that's got a value point to it, right? And you can use that is that something that you can use to make a decision about an increased cost? Maybe, but it depends on who's asking and who's, how that information is presented. But I love where you're going with that.
You're right. And then, the thing is that, like everything in life, we have to demonstrate that ergonomics, going the detrimental, it may be even affecting the performance of the surgery. You feel tired and you just become sloppy,
That's right.
And if, for example, if you ask a hospital to spend a little money on protecting you from X-ray exposure, they don't have a problem on that, So,
that's right.
But then with the vision is similar to that, how can I document it that actually having this technology, I'm protected, patient is protected, everything is more clear. So that makes sense for the hospital to for the health system
Sure,
or that piece of expense on the procedure,
Well, I can't thank you enough for that, and for all the support. I mean, you're the first surgeon that I've had on the Sultans of Sales podcast that has actually used the product that it represents. So it's really awesome for me to hear this. And, as I go out and try to, we collectively with Matt and the team, who we're all big fans of you and what you're doing as we.
And I want to make sure, Jay, that this is not a infomercial or something like that. We're doing this one as I'm telling you because I like the technology and I love it, not because you work on vision or whatever. I'm consultant on it.
Thank you. And again, I wasn't sure kind of how it was going to be addressed. It's a question that I would ask, even if we weren't recording, I would ask your experience. And, again, part of this podcast, the reason I started doing it back in June of this year was to capture some of these great discussions that we're having that I love and that I enjoy. And I feel grateful to have with clinicians, with leaders, with other folks, and then share that at scale so that other people can glean and learn and improve and be inspired, right? Because of that discussion. And, so again, thank you for carving out time. And, I really appreciate you. I look forward to seeing you in person here. In I guess just a couple of months. In Las Vegas.
Awesome. And, as always, you're welcome to, come to witness my surgeries, and
I will
have a good time and you see how we struggle and we get through it.
But the struggles are
life.
Struggles are part of life. They're part of surgery.
Exactly.
It's where things change. It's where things innovate, right? It's, hey, how can we make this better? To your point, incrementally, how can we make surgery better? And then therefore, hopefully that has a trickle down effect to outcomes and to how things are done going forward. So
correct.
I'm proud to know you, Juan, and thank you for this time. This was wonderful. I don't want to take up too much of your day. I know you're busy, but enjoyed it.
No, it was a pleasure to talk to you, Jay, and share what I love, which my passion is spine, and nothing better than in your platform.
Wow.
So let's keep in touch.
This is great. Yes. Thank you so much. I'm going to close with that. Juan Uribe at the BNI in Phoenix. Exceptional. Thank you so much for joining. Thank you all for tuning in, and tune in next week. Hang on just one second.
Thank you.